I would like to present to you my presentation about the endovascular management about the endovascular management of aneurysmal subarachnoid hemorrhage, presented by me, Mohammed Salam Andreas, Senior Resident of Neurosurgery, Tanta Faculty of Medicine. The aneurysmal subarachnoid hemorrhage is a neurological emergency characterized by extravasation of the blood into the spaces covering the central nervous system that's filled by cerebrospinal fluid. Starting with the anatomy of the cerebral circulation, as we know, we have the aortic arch giving the main artery supplying all the cerebral circulation, and we have the circle of Willis, which connect the carotid system with the vertebrobasilar system by the anterior communicating artery and the posterior communicating artery. And here are the most common sites for the intracranial aneurysms. We have the anterior communicating artery aneurysm, BCOM aneurysm, and the basilar tip aneurysm. Intracranial aneurysm are acquired lesions accounting for 80% of non-traumatic subarachnoid hemorrhage, with a prevalence of 3.6 to 6.5 and with a ratio of 3 to 1 in the woman to men. We have the pathology of the intracranial aneurysm may be saccular, fusiform, giant or dissecting aneurysms. The clinical presentation, we have variable degrees of the presentation, starting with disturbed conscious level with deep coma, may be presented with headache, loss of consciousness, vomiting, seizures, and unusual headache, neck, and backache. The grading of subarachnoid hemorrhage, we have the Hunt and Hess scale grading the subarachnoid hemorrhage in the clinical state. The World Federation of Neurological Surgeons scale. We have the Fisher scale, which grades the amount of the subarachnoid hemorrhage in the CT scan, and the well-known Glasgow Coma scale, and two scales, Glasgow Outcome scale and the modified Rankin scale for detection of the outcome. The imaging of subarachnoid hemorrhage can be done using the CT scan, which is the initial diagnostic modality. CT angiography with a sensitivity up to 99%, which is very important in the pre-therapeutic phase. The MRA, which is used for screening of aneurysm and follow-up of patients who underwent endovascular therapy. And the catheter angiography, which is the gold standard for detection of cerebral aneurysm. The endovascular therapy started by the IZAD study, which was the first randomized prospective controlled trial, the international subarachnoid trial, which compared the coiling vs clipping for ruptured aneurysm, suitable for both treatment modalities, either clipping or coiling. Here we have the standard surgical clipping for the aneurysms, closing the aneurysm from outside using the surgical clips, and here the endovascular coiling, filling the aneurysm using the catheter to fill it with the coils. Endovascular therapy had different techniques. We have the parent artery occlusion. We occlude the main vessel carrying the aneurysm, leading to its occlusion. We have the endosaccular coil embolization, which was started by the introduction of the Guglielmi detachable coil, GDC coils. We have also the balloon remodeling technique. We use an inflatable balloon at the neck of the aneurysm to allow more dense packing of the aneurysm and also prevent the prolapse or migration of the coils from the aneurysmal neck, and this is very suitable in the cases of wide neck aneurysms. Also, we have the stent-assisted coiling and the flow diverters, which is used in the parent artery carrying the aneurysm, which divert the flow directly into the main artery and away from the aneurysm, leading to its closure later on. And also we have the intrasaccular flow disruptors, which disrupt the flow away from the aneurysm. And this is the evolution of the endovascular therapy from coiling, the flow diverters, and the web device. Our aim of the work was to evaluate efficacy, safety, outcome of endovascular therapy for aneurysmal subarachnoid hemorrhage. The study conducted on 25 patients with aneurysmal subarachnoid hemorrhage at Neurosurgery Department, Tanta University. 5 patients had endovascular therapy during the first 48 hours, 20 patients between 3 to 13 days. No pre-procedural systemic anticoagulants. We used the standard transfemoral approach, high resolution monoplane rotational fluoroscopy. We use the 5 French diagnostic catheter, and then we exchange this catheter with using a 6 French guiding catheter. Then we use the micro catheter, which was Excelsior SL10 and A10-18. Then the micro catheter was shaped by steam, and the navigation of this micro catheter to the aneurysm using a micro wire transient. We used different varieties of coils using GDC and target coils. Endovascular therapy succeeded in 24 cases and aborted in only 1 case. Angiographic and clinical outcome was assessed using Raymond classification and Glasgow outcome scale. We had a mean age of 47.5. We had 60% of our patients were female. The most common risk factor was hypertension in 15 cases. And the clinical presentation, most of patients, 10 patients was presented with Hunt and Hess grade 2 and 8 patients with Hunt and Hess grade 3. The aneurysm location, we had 12 ACOM aneurysm, 10 PCOM aneurysm, 2 MCA aneurysm, and 1 anterior choroidal aneurysm. The size of the aneurysm, most of the aneurysm was small aneurysm, and we didn't have any giant aneurysm. The immediate outcome, clinical outcome, we had a good recovery in 16 patients. The complication of subarachnoid hemorrhage, we had vasospasm in 3 patients, hydrocephalus in 4 patients, and for the complication related to endovascular therapy, only 3 cases had device-induced vasospasm, 1 thromboembolic event, and 1 perforation. I will present only 2 cases of our work. First case with a female patient, 55 years old, presented with subarachnoid hemorrhage. CT angiography showed a large BCOM aneurysm. The patient had a replening. Here is the early CT scan showing the subarachnoid hemorrhage. And here is a follow-up scan showing the bleeding with hydrocephalus and the intraventricular hemorrhage. Here is the CT angiography showing the large BCOM aneurysm. Here is the aneurysm measurements and the 3D measurement. Here is a compartmental filling of the aneurysm with the coils. And here we can see the working view with complete filling of the aneurysm. Here is the aneurysm, and here is disappearance and the complete filling of the aneurysm. Here is the lateral view. The second patient was a female, aged 60 years old, presented with subarachnoid hemorrhage. CT angiography showed middle cerebral artery aneurysm. Here we can see an EB view with the aneurysm, and here is the disappearance of the aneurysm after coiling. Here is a lateral view, and here is a working view. Here is the aneurysm, and here is complete filling of the aneurysm. Here are the stages of the aneurysmal coiling, the framing, the filling, and then finally finishing the coiling of the aneurysm. And there is selective injection of the aneurysmal neck. Conclusion: endovascular therapy was an effective and safe technique for treatment without any treatment-related morbidity or mortality. Hunt and Hess grade at presentation and vasospasm were the main risk factors affecting the clinical outcome. Despite the good angiographic and clinical outcome, still longer angiographic and the clinical follow-up is mandatory in all cases. The community added value, we provided a better diagnosis and management of subarachnoid cases, providing a minimally invasive technique for major disease, early management of the aneurysm cases with low risk and good results. Thank you.